this series on, and I am excited for you guys to meet Dr. Williams. She is amazing. She is very near and dear to my heart. Um, and she will bring you guys a lot of information today. So I want to thank her for joining us on this journey. Um, and I want to give the mic back to Adele.
You muted.
Thank you, Kara. And I'll actually have Kara introduce herself a little bit in one of the slides, but you're in the right place if you're here to talk about maternal health with us. So actually, Dr. Williams, if you would mind proceeding to the next slide, please.
Yeah. Oh,
So some of y'all are familiar with healthcare education training. For those of you who aren't, healthcare education training, HCET for short, um, we bring sexual health and wellness to communities. That's our bread and butter. Part of that is we have a big arm that's trauma-informed care through our Midwestern Trauma-Informed Training Center. So actually, next slide, please. I'm going to invite Kara, the director of the Midwest Trauma-Informed Training Center, to talk about that really quickly.
Cool. Very briefly, my name is Kara Bergronick. I am a women's health nurse practitioner by background, and I serve as the director of MTITC, as well as the director of health strategy and advancement at HCT. And HCT formed MTITC back in 2023 when we recognized a need to help bring together some of the kind of disparate and siloed work that was happening around trauma-informed care in our region. So many folks are doing this work, and just not knowing kind of what the left and right arm are doing. And as you all probably know better than almost anyone, so often this work is the sort of unpaid labor piece of making good healthcare, right? This isn't necessarily billable. Creating these resources and all these things are again, don't necessarily fit in our normal workflow. And so that's one of the places that HCT is really happy to be able to step in. So our North Star is to transform the landscape of health and human services by creating a workforce that is fully equipped with what they need, knowledge, skills, and resources to make trauma-informed care standard of practice wherever someone shows up for care or services. So that is who we are and what we do. And again, grateful for this partnership and this project. I'll let y'all keep rolling.
Awesome. Thank you. Next, please, Dr. Williams. And this is pretty standard Zoom stuff. If you're familiar with Zoom, if you're not, here's a little tutorial. We are going to use Q&A for this webinar just because it saves your question. So then we can address it anytime. If you do put a question in the chat, I just don't want it to get lost. So that's why we use the Q&A function. So please use that. You can find it at the bottom. And actually, you know what? I don't even know if I'm seeing it. Yes, it is there. Okay, just checking. You can put things in the chat too. If there's ways that you want to interact. If the Zoom polls aren't working for you, use chat. But for questions, please put them using the Q&A icon. Thank you. Next, please, Dr. Williams. And then if you would like, oh, you're good. You can stay here. Don't worry.
okay.
If you would like to see subtitles or like a live transcript, there's a little CC icon at the bottom that you can click on to add subtitles. You can read what we're saying if that's your preferred way to access what's happening today. And then just a couple of housekeeping items. There is an eval. It's pretty short that we would love to have you fill out after this, just to tell us what you thought, let us know what you want to learn about in the future, how everything went. So please work with us to fill out that eval if you have the time. We do a QR code, a link. We'll send it to you in an after email with everything. One important note about the after email. So if you did not register for this training, so let's say you got the link to join from a LinkedIn or from a friend, you are not on my list to send the follow-up email to. And Dr. Williams has some really cool resources in the follow-up email. So I'm going to put my email in the chat. If you send me an email and say in the subject webinar, then I know you were here and I will send you the follow-up email. So you don't even have to put a body in the subject. My name is Adele. I'll put that, Adele White. But just email me and just with the subject webinar, and I'll know to send you the follow-up email that goes with this because it does have some important resources that Dr. Williams is passing on to you. If you have any technical difficulties during this, please email updates@hcet.org. My colleague Jen monitors that, and she can help you out if it's something that we can fix. Oh, Debbie, thank you. The only thing, Debbie, I apologize, I cannot see your email here, so you do have to email me. I apologize for that extra step. But if you put your email in the chat too, I can copy and paste it, but otherwise just shoot me an email. Thank you for doing that so I can tell everyone. Next, please. So this webinar does you are able to claim nursing contact hours if you would like for this. So what is required of that is you attend the entire webinar, you complete the evaluation pre-test, post-test that allows you to answer the knowledge questions that are required, and then you email me the form. The nursing contact hours form will be linked in the thank you email afterwards. So you will get that as well. But again, if you want to claim nursing contact hours, super important that I have your email so that I can get all these things to you. Thank you so much. Next, please. And then this is just if you want to learn more about us, if you want to check out lots of our other trainings, we have dozens, hundreds. I should actually count so I can give you a real number. We're on Facebook, LinkedIn. Our website is hct.org. You can find us everywhere and check out. We have a lot of really cool trainings. Next, please. And then I'm actually going to let Dr. Williams introduce herself, but we're really, really excited to hear from you today. So please take it away, Dr. Williams.
Yes. Hey there. I am Dr. Tiffany Williams. I work at Indiana University School of Medicine and Indiana University Health. And I conduct research, I train students, and I also have a clinic where I see patients and am excited to share some knowledge with you guys today. Um, so the rest is me, right? Okay. And just so that I'm keeping track, it says 12:10. So I need to be done by what time?
Yeah, so we have
1:10? Is
we
that
have until 1:15.
one?
We like to leave
One.
about at least 5 minutes for questions, but I'll
Okay.
remind you when you have 10 minutes left.
Perfect.
Okay.
Okay. Excellent. All right. So just want to make sure we're on the same page. So welcome everyone. Thank you so much for taking the time to spend your lunch hour with me. So I have quite a few things that I'm going to share with you guys today related to Black perinatal mental health. We're going to talk about trauma-informed care and bias-aware clinical practice. So when I came up with this title, I don't know, 3 or 4 months ago, and I was like, oh yeah, I'm going to make sure that everyone leaves this space and they're going to be bias-free when they engage with patients. And then, like a few weeks ago, when I actually started doing the slides, I was like, wait, that doesn't make any sense. Like, everyone has biases, everyone has assumptions. What's really important is that we're aware of them and we don't allow them to interfere with the work that we do. And so I put a little slash out of bias free and turned it into bias aware because really that is what I want all of us to do, is to be aware of our biases when we are engaged with patients and clients. All right, so let's get started. So the agenda for today is I'm going to take you on a journey. We have a patient case, totally fictional, but one that might resonate with some of you. And we're going to walk through what trauma-informed care can look like with a patient. And so we will go through each of these stages. Recognizing is in the beginning, noticing, interpreting, responding, and reflecting. All right, so I thought it'd be a good idea to start with some stats. What do we know about maternal mortality? And so, well, obviously it's not good and it hasn't gotten any better. So, national data reflects that 22% of pregnancy-related deaths are related to an underlying cause of mental health conditions. Okay. And so, essentially, we really give credence to some of the obstetric complications that we know to cause mortality rates, hemorrhaging and gestational diabetes or, cardiac conditions, hypertension. But I don't know that we give the same level of vigilance to mental health conditions. And so I thought it'd be a good idea for to really advocate for us to be more mindful of how mental health can relate to pregnancy related deaths. And this is an angle that we can take like we do with some of the other common obstetric complications that women face. And so, as you can see here at the bottom, obviously, this number is not just racial ethnic minorities. This is all of the states. But in the bottom here, you can see that Black women, 7% of Black women experience mental health conditions accounted for underlying causes of death for them. Okay, so let's get to the next slide. So I thought it'd be a good idea. Okay, well, we're talking about nationally what's happening. Now let's talk about where we're at. So I'm in Indiana, and it's not looking very good here either. Okay. And so the mortality rate for infants and for moms is pretty bad here, not good. And some of the data shows that of those deaths, about 81% of them could have been preventable. Okay, there was a good chance that we could have done something to intervene. And another astounding statistic that I learned about when I moved here a couple years ago is the lack of access that some of these counties have. So, 23% of counties in Indiana are classified as maternity care deserts. So, essentially, these women do not have access to the care that they need. And so, Indiana has some pretty bleak outcomes, but we can intervene. We can intervene. And that is what I'm here to talk about, a way that we can intervene so that some of these women are seen and heard and treated. So, what you're going to learn today with me is we're going to talk about some common perinatal mental health conditions, anxiety, depression, PTSD, suicidality. We'll talk about the ways in which structural and systemic factors contribute, and chronic stress contribute to mental and physical health outcomes for Black women. We're going to talk about a case, and what can trauma-informed care look like when we're actually with a patient, with a client. And of course, we're going to apply that. And so at the end of the presentation, you guys will get like some documents from me that I made especially for y'all so that you can be reminded of what this can look like in your care and you can just refer back to the slides, in the future. All right. So let's start with recognizing. So this is part one. Basically, recognizing means recognizing that mental health for Black moms, Black babies is as important as the common obstetric complications, the adverse pregnancy outcomes that these women face. We need to give the same clinical vigilance that we do to those, to the mental health. Why? Because the mental health of the mom while pregnant or postpartum can affect long-term health conditions for the mom and the child. And so we need to recognize the scope of this issue by staying abreast, staying aware of the data, like what I was showing you earlier from the CDC. We need to recognize the ways in which barriers and structural concerns might influence our capacity to capture when someone is in distress. And then obviously we need to walk in with the mindset of trauma-informed care so that we don't miss anything. And so, like at the end of the introduction slides, you'll see like a goal, what I want you to take away from the story. And in this case, it's that recognition needs to be a clinical priority. All right, so you're in a room with a patient. What do you notice? What does distress look like? You know, um, What we know is for mental health conditions, a lot of the symptoms that we see, they overlap. Okay, so some symptoms might look like depression and anxiety, or, some symptoms might look like PTSD and anxiety. What do we go to? What's our norm? Like, what's the signal to us that we might be seeing some of that in the patient that comes to our room? So essentially, these are signals. These are not like one all be all, so we need to be curious about when we see signals like these and when we're not seeing signals because they don't look like these. You know what I mean? But these are opportunities to explore. All right, let's see. I think we're going to meet. Oh, Right. So before we meet our case, let me orient you. So for this presentation, I thought it'd be a good idea to stick with a clinical model that's based in evidence and a trauma-informed care approach that's also based in evidence. And so we are using both of these lenses today how we're going to respond to our case. Okay, so this is the way in which we engage the clinical encounter. And then SAMHSA's trauma informed approach is the lens that we use to engage the patient. Okay, and so you're going to see me referring to each of these quite a few times throughout the presentation. And again, in your materials, you'll have like the resources and sources so that you can look them up yourself should you want more information. Okay, so you'll see from the clinical judgment model, we're going to go from noticing to reflecting, and then when we actually engage the patient, we're going to do realizing, recognizing, and then responding. Okay, because at the very end of the day, we do not want to re-traumatize the patient, correct? All right, so let's start with noticing. So, noticing, what does that mean? Well, what are we seeing? What does distress look like? What are we used to distress looking like when we see a patient? What could we possibly miss? So, when a patient walks into your room, what are they showing us? What are the cues that might be an indicator? So, we just saw some previously in the slide: hypervigilance, difficulty focusing, things like that. Those are cues that we can pick up on. What are we assuming? Just because we've seen other patients, are we walking in with any assumptions about what the presentation is supposed to look like? And then like what would make it harder to see? So what could we miss because we're so focused on the clinical cues that we're used to seeing? So I'm hoping by the end of this section, you'll be able to notice meaningful cues, set aside assumptions, and stay curious about the patient before moving to interpretation, which is the next section. Okay? All right. So again, just to recap before we dive into the case, Black women are disproportionately experiencing maternal deaths and their infants. I'm not talking about the infants here, but they're not in great shape either. And it's 3 times the rate of white women. And the point that I want to make with this slide is 3 times the rate, something else is going on. This can't just be an individual risk. Like something else has to be shaping, why so many women are passing away when they're pregnant or after, they've given birth. And so I wanted to draw your attention to this is not an individual risk factor. This is something that's happening outside of the woman that might contribute to increasing the risk for death. Okay, so this is Tasha. This is our case, and we'll have this whole case for the rest of the presentation. And this is totally fictional, so not based on any patients or anything, but probably a typical patient that you would see in your office, whatever practice you do. So Tasha comes in, routine prenatal visit. She's 28, 24 weeks pregnant. She has a baby, 3 years old. She works full time as an HR rep, and she identifies as Black, cisgender woman. What does she say? Everything's fine. I'm all right. I'm just tired. So, poll number 1, Adele. What are you noticing? Does the questions come up too when you put the polls? Okay, good.
Yeah, there you go.
Perfect.
You should be able to see it now.
Bet. Okay. So, poll number 1. And I want you guys to, just plug in what you think, what you see. What stands out to you most about Tasha right now? So, those are her symptoms. This is what she's saying. Give you guys a few minutes.
Yep, I see we have about 25 people participating. I'll just wait like another 15 seconds and then I'll show you the results.
Perfect.
Yeah, we have some variety. I love it.
Good,
All right.
good.
About 40 of you participated. We'll just give it a couple more seconds. Okay, some stuff still coming in. Thank you everyone for taking the time to participate in these, poll engagement pieces. It's really helpful just to guide our discussion and see where y'all are. All right. I am going to go ahead and end the poll. Thank you so much so y'all can see the
Perfect.
results.
Okay, what'd you guys say? So, yep. Fatigue, limited sleep, yep. Worrying, concerned about the baby. Uh-huh. Yeah. She's still working. She's still taking care of baby. Okay, a little, some of y'all said, not really that concerned yet. Makes sense. Okay. Bet. Excellent. No right or wrong answers. Okay. All right. Agreed. Not sleeping very well. Fatigue, is prominent. And she's got some checking going on, checking for movement from baby, some worry, right? And yes, still working, but having difficulty with focusing. All right, so let's move on. Okay, so here's the thing. Yeah. She's working, she's managing, she's taking care of 3-year-old, right? She's doing her job. She even came to the appointment. She's engaged, right? She says she's fine. Maybe she is. Here's the thing. We don't want to assume that because a person is functioning, they're fine. Okay? So when you get this patient, Tasha, come into your office and see you and she says all those things, what story might we tell ourselves about Tasha? It could be the things that we mentioned here, right? She says she's fine. She's probably okay. Maybe she is. But the idea is to be curious. We don't want to draw any conclusions or assume, right? So just because someone is functioning doesn't mean that they're okay. Functioning tells us what someone is doing. It doesn't really tell us how they're doing, okay? All right. So let's talk real quick about, so remember that slide I had about um can't be an individual risk. Like there's the rate of death is too far. Three Black women dying 3 times the rate of white women just seems to be too profound for it to be an individual characteristic alone, something, with the the patient. And actually it's not. Like there are quite a few things that Black women encounter every single day that shape their health, their mental and physical health. Some of that is gendered racism, and I've done a lot of work with colleagues around gendered racism. Gendered racism is the intersection of experiencing racism and sexism. And this is when we operate from a lens of stereotypes. All Black women are angry. So when we see them, we make that assumption. Oh, well, she has an attitude. You know, that is a racism. We um, also, Black women face, systemic and structural discrimination. Maybe they don't have the resources that everyone has, or maybe they don't have the access that everyone has. But these conditions also shape the way that Black women's health and mental and physical health and their healthcare experiences. Oh gosh, I have so many conversations with people, not just patients, about how they walk into an encounter, a clinical encounter, and they don't feel heard. They felt dismissed. They were ignored. They were mistreated. All of these things, right? And so Black women have to navigate all of these systems each day. And what that can do is create cumulative stress on the body, cumulative stress on the psyche, the mind. And so, in order for us to enact bias aware engagement, we need to be mindful of all of these contexts, all of these systems that Black women endure each day and how that might shape what they're coming in with when we see them. Okay. And here at the bottom of the slide is repeated exposure. So, like, this is something that Black women endure every single day they get up and leave the house. Maybe they don't even need the house, leave the house. They can look at their phone and they're exposed to things, that might cause them stress or that might wear and tear on them. So adaptation, like resilience and support and all of these things can help mitigate some of these things for Black women, but they don't erase them. They don't change them. So spent too much time on that slide, but obviously I'm really passionate about this. So let's talk about strength, right? Tasha walks in and, she looks fine, right? She's she may not even look the way that we perceive distress to look like. Maybe she looks like she's holding it together and she's pushing through, raising her baby and working. Maybe she has had to learn how to be self-reliant and independent because there's no one else to help her. And so she's got to make sure she gets up and go to work, and she's got to make sure she picks up the baby from daycare or whatever. You know, maybe she doesn't really show a ton of emotion because she's learned to protect vulnerability because of all the systems that she's had to navigate that we just talked about. Either way, strength and distress can coexist. They can live in the same space. And our job as clinicians is not to dismantle that. Our job is to make room for vulnerability so that the patient can tell us what's going on with them. We need to create space for them. We need to create that atmosphere so that they can, share with us what's actually going down. All right. So, yes, clinical takeaway, be curious, ask, listen, create safety, check your biases. Because what we think we know, what we think we've seen, may not necessarily be what's happening in front of us in that moment. So, disclosure is only part of recognition. We need to make sure that we are not doing what others and other systems do to patients. We need to listen, we need to respond meaningfully. We need to be aware of our biases in the background or what we think we know. And we need to work together with the patient, with the client, so that they have some say, they have some agency in their planning, their treatment planning. So them telling us is not enough. Disclosure is not enough. We need to let them know that we hear them. That's the only way that you're going to build trust. And after you get trust is when you really start to get, down to business. Well, what's going on with you? Maybe the patient will feel open and comfortable sharing whatever it is that's happening with them. Okay. So yes, recognition is a shared clinical responsibility, and it is not up to the patient. It is up to the clinician to ensure that the patient feels safe. So again, we do not want to silence, minimize, or dismiss the patient. They get that enough when they're outside of the clinical space. All right. So yeah, let's talk about what distress looks like. Sometimes it's hard to see. We in our minds, because we've seen so many patients, we may have a template for what we think distress looks like on someone, you know. Um, but it doesn't mean that it's necessarily going to look like that when a patient walks into your room. We need to ensure that we're understanding what the patient is communicating to us, and how they're coping with whatever it is that's going on with them. And we just need to make sure that we're responding appropriately. Again, with being bias aware, what we bring to the table, and making sure that it doesn't interfere with our clinical judgment, our clinical assessment, and our clinical response. So yes, recognition happens as an interaction. It's done with the patient. It's a relationship that, you have with the patient, and you want to make sure that they don't carry the brunt of the responsibility. Okay, I'm doing good on time. All right, so before we jump into the next phase, so we were talking about noticing, remember? So like, what are the signals? What are the cues that the patient's given us? That might be an indicator that something's going on. And so now we're going to dive into interpretation, but in the back of our minds, we want to make sure that we're noticing the actual person, We're listening to them. We got our biases checked. We put them on the shelf, right? We understand the context and how these women, that come into our offices, how they're situated across the systems in which they operate, and how that might contribute to what we're seeing. And respond with partnership. Like this is we do it together with the patient. All right, so interpreting. Noticing gives us the signals, the clues, right, of what could be happening, but it doesn't tell us the whole story, right? We need to look for possible explanations for what's going on, by examining clinical, cultural, biological, systemic, all of the factors that shape, the woman's functioning, their health, mental and physical health. So, interpreting, is exploring clinical explanations. What could possibly be going on? Instead of settling on, oh, must be this. Understanding the impact of chronic stress and how systemic oppression, all of the systems in which these women are situated have adverse cumulative effects on their well-being. Recognizing biases and how barriers might impact their capacity to access or get the treatment that they need, and then connect the dots in a meaningful way, right? So when the threat system stays on, essentially, some distress presents as protection for some, not withdrawal. We need to make sure that when we are keying in on what's happening with the individual, that we are not locking in on just, oh, must be that. So if someone indicates hypervigilance, is it showing up the way that we think? Is it showing up the way that we've seen? Or are we listening to see what's actually the patient is presenting us with? Remembering that the signals that are given to us could be multiple explanations. Maybe arousal and hypervigilance is PTSD, and or maybe it's depression, you know. Maybe cognitive load, inability to focus is ADHD or something. We don't want to jump to conclusions. We just want to understand that these are responses to stress, and they can have a cumulative effect on the mom's health and well-being. So what about Tasha's behavior could be communicating a sense of threat? She's mentioned sleep issues. She's mentioned checking fetal movements quite a bit. She's talked about worrying some. So basically, what we're doing is we're gathering evidence and we're searching for possible solutions without immediately jumping to the conclusion that it's this, if that makes any sense. So down here, the Q gives us a hypothesis. That's what we want, not a conclusion. You'll get to the conclusion should you listen and hear what the patient is saying through and through. So this slide right here is just reminding us of the ways in which stress can be embodied. Okay, we get someone who is exposed to chronic, structural conditions, racism, discrimination. What do? Those experiences affect the way in which the mind and the body operates. You can experience physiological responses to these experiences, these exposures, that can create a cumulative burden over time. This is where weathering comes in, where your body just takes a toll, over time. And all of that intersects to create mental and physical conditions, like medical health conditions. And so we need to be mindful of this process, this stress process, as we're engaged with patients that come to see us. This is what is happening behind the scenes that we don't see, that we need to account for when we're trying to understand what's happening with the patient that's seeing us. So essentially, we need to be aware of the ways in which these happen. That is how bias aware operate. That's how it works. If we know that when patients walk into our space, these are the things that they encounter potentially, then we can make sure that we keep that in our mind when we're making the clinical diagnosis and formulating the plan and working with them. So stay curious, check assumptions, hold multiple possibilities. That is the nature of this interpreting.
And Dr. Williams, just holler at me when you want there to be a poll. Um,
Yes, I skipped one.
oh, that's okay. Yeah, you just let me
Yeah,
know
but there's about to
whenever.
be one right now, so
Okay,
stay
cool.
tuned.
Sounds good.
All right, so back to Tasha, okay? So Tasha comes back in, right, for a checkup. Now she's 28 weeks, right? What does she say? I'm okay. Just tired, still just tired, you know? So, okay, we're ready for that. The poll three now, because we skipped two. All right. So you look at this, you see what she comes in with. What explanation comes to mind first? So, like your first thought, what are you drawn to immediately at the gate?
All right, we have a couple responses coming in. Everyone putting their thinking caps on, definitely. This is a big question. Okay, I'm seeing some people thinking hypertension, anxiety, chronic system stress, more than one process, need more information. We're really all over the board. I'll give us like another
Good.
30
Yeah, yeah.
seconds. Yeah, this is great.
And did you reach for first? Like think of it like your first, where does your mind go to immediately? And then I also think about, well, what influenced it that your mind went there?
Mm-hmm. All right, I'm going to open seal over for just 5 more seconds and then we'll close.
Okay.
All right, and poll and share.
Okay. What do we got? Yes, I love that. More than one process may be occurring. That's great. Yes. Uh-huh. Hypertensive. Woo. Yeah, her blood pressure then went up, didn't it? Uh-huh. Uh-huh. Anxiety could be. Yeah, yeah, could be. Yeah, could be. So it could be one or all of those things, right? Essentially, we we don't want to miss something by jumping to the conclusion that it's hypertensive disorder and then nothing else, not thinking, outside the box could be something else. We don't want to psychologize the physical and overlook the psychological, okay? So with Tasha, we want to be curious. Okay. So I see some things have changed. Um, so let's move on. So, some of what you guys mentioned. Yes, one explanation can be true, but it can be incomplete. Maybe there's more than what we think is going on. The problem is when we jump on one thing, oh, hypertension, and then we neglect any other signal that we saw, right? Could it be pregnancy? Possibly. Of course, she's tired. Why wouldn't a pregnant mom be worried? She's bringing a baby into the world, and the world is crazy. You know what I mean? Is it anxiety? Could be. She's been checking the fetus, making sure everything's okay persistently. She's having some difficulty with focusing, and she's got some worry going on. It's hypertension? Maybe, because her blood pressure was elevated for sure, even the repeat, right? Could it be stress? Sure. But what if more than one story is true? Let's say if we just jumped on the hypertension and neglected all of the other possibilities, we might prematurely close the case and create a treatment plan just based on, oh, let's get her hypertension under control and send her on her way. That's when diagnostic overshadowing can happen. And it's when we allow one condition or interpretation to make other clinically important concerns less visible. And we don't want to do that. That's how we miss. right? That's how we get to that 22% that we mentioned in the beginning as mental health condition being one of the underlying causes because we missed it. And this is a preventable condition, you know? So we need to make sure we take the whole person in mind and not jump to the first thing that we think is happening with the patient. And over here, each time, each encounter, we're checking in with our biases that's on the shelf, to make sure that we are not assuming just because we've seen other patients like this or just because we think we know what distress looks like, we're not making any assumptions that might be interfering with our clinical interpretation. All right. So now we're going to respond, right? We're going to respond to Tasha. And what do we want? We want to respond with skill, compassion, and equity. We want to make sure we're building trust, right? So that the patient feels comfortable in sharing with us what's going on. We want to build safety. We want to be curious, about the patient with intention. And we want to think about the whole person. We don't want to just jump to the first thing that oh, hypertension, and move on and go to the next patient. And then we want to work with the patient as a partnership so that they're involved in the treatment planning. Um, all right. So the way they respond is a three stage model. So, oh, by the way, this is a time when I can start mentioning. So I created a clinical conversation map for you guys, which you'll get after. So make sure if you um, did register, you email Adele if you want this because she doesn't have your information if you just got the link sent to you. But you in the clinical conversation map that I created, it'll have like a list of things that you can say under each condition, each step, each phase, so that you can try it on and make use of the skills that you're learning today and make them your own. So we'll start with acknowledge and we'll jump into assess and then act. All of this is our attempt to respond to what the patient has brought to us. Okay. And then we'll do this with Tasha. Okay. Essentially, if we use this, we are creating safety, trust, we're being transparent, we're working with the patient collaboratively, we're making sure our biases are still on the shelf, and we're hearing the patient and giving them voice. All right. So let's start with acknowledge. So these are some ways in which you can acknowledge, okay, with the patient. Before asking for more, create the condition in the clinical space for the patient to feel safe answering what it is that you're asking. And the way to do that is through these steps. You're validating, you're explaining, you're asking permission, and you're inviting. So what that could look like is uh, you've been carrying a lot, or you've described very little sleep, a lot of worry, and trying to keep everything going. You're basically validating what she's saying. Like, wow, okay, this is happening. You can explain, listen, this is why I'm asking about X, Y, and Z, because well-being is a part of mental health, maternal health, and it's important for me to know that you're okay. You can ask permission. Would it be okay if we dive a little bit deeper into, whatever is going on? You mentioned checking the fetus a lot, um, asking permission. And then, leaving the door open, invitation. Tell me more about what the worry has been like for you, you know, and then let them share whatever it is that's on their mind. So again, we want to operate from a lens of curiosity, and we don't want to tell them what we think they're feeling. You know what I mean? So, like, for example, you seem really anxious. Instead of saying that, maybe you've mentioned a lot of worry. Tell me more about that. You see how that sentence can change the way in which someone responds, you know, and give us information that could be vital in our clinical response and diagnosis. So then assess, start with the broad, invite the patient's experience. How have you been emotionally? Go deeper. These are ways that you can do that. What are you thinking? Functioning, context, support. What makes things harder or what's helping you cope? Open-ended questions, curiosity, and then always assessing for safety. And again, all of this stuff and some more examples of how to say things is in the clinical conversation map that I made you guys. So here's a moment to pause to ensure that we're engaging in bias-aware encounter. Am I bringing the same depth of curiosity and concern to this patient that I would other patients? So essentially, when we're asking these questions, we're creating safety and we're asking questions in a way that invites, deep level conversation about what's going on with them. And then the action part, what do we do? Partner with the patient. It's a collaboration. Decide with them, what kind of support do you feel would be useful right now? I see that you're taking care of your daughter and you're going to work, what would help you balance the two, at this point? What barriers do you face? Maybe oh, you don't have childcare, so you're forced to do X, Y, and Z, or oh, your car is broke down and now you got to take the bus. You know what I mean? Like, be curious about the context in which patients, might experience things that affect them, and then when you're connecting with a mental health care professional, move beyond just, all right, here's the name of a person, go find them. Now you done left it up to them, the onus on them to go and find this person who may or may not respond, to see. So, always follow up to ensure that the needs of the person is getting met. If you provided information for them to meet with someone to help them with their mental health, follow up with them to see what happened. Did you contact this person? Well, you did, and they didn't respond. Oh gosh, let me get you someone else. Or I know someone, you know. So always follow up and always ask yourself, am I offering the same options, urgency, support, and follow through I would offer another patient with these needs? All right, so uh, one more encounter with Tasha. So I thought it'd be a good idea to give you a general sense of how are we doing on time? Okay. To give you an idea of what two interactions can look like. And this is not by any means a bad interaction. Okay. So I wanted it to be like a typical interaction, right? Because we're busy, we're seeing a million people a day, And so the first interaction with Tasha is the task focused, right? So let's read it. So this is, well, like I said, well-intentioned, warm, you're getting the job done. Tasha comes in, I'm okay, just still really tired. So I say, clinician, I hear you. Pregnancy can be exhausting, especially when you're working and have a little one at home. Are you feeling depressed or anxious? No, I don't think so. I'm just tired and probably worrying too much. Me, clinician. Okay, that's understandable. Just keep an eye on how you're feeling and definitely let us know if it gets worse. What happened? Think to yourself, like, how many interactions have you had like this, right? Seems innocuous. You care, you're warm, pleasant. What happened? Reassurance came before exploration. A closed question narrowed disclosure. Responsibility shift back to Tasha. Uh, Let us know if anything gets worse. And like I said, no one was uncaring, intentionally or malicious or anything, right? It's just a regular encounter. Now let's see what a trauma-informed, bias-aware encounter could look like, right? Why not? So this is curious, collaborative, open space, right? What we've been talking about. Tasha, I'm okay, just still really tired. Me, clinician. You've mentioned very little sleep, a lot of worry. Would it be okay if I asked a little bit more? Tasha, yeah. Clinician, when you say you're okay, what does okay look like day to day? What changed? So now she about to explain to me, well, a description of what her day to day looks like as it relates to what's worrying her, you know? And so observation was acknowledged. We asked permission to talk more about it. Open question invites reflection. What is going on day to day? Chances are she may not even know because she is doing the day to day. She hasn't stopped to think, what's worrying me? But maybe that's a process that you can have with her so she can be more aware, not just to let you know, but to let herself know. And then you create the space for fuller disclosure. So she gets to lay out, well, honestly, this is what's been going on, right? So a trauma-informed and bias-aware encounter can open the door for understanding more of what's going on with the patient. And these small shifts in how we engage with the patient and how we respond can make things that are not visible more visible so that we miss less, if that makes sense. So, recap, what did the trauma-informed bias-aware approach do? It created essentially a deeper understanding and maybe even empathy and support, you know, um, for what's happening with Tasha. And so look, let's let it play out some more. So acknowledge. So these are the skills that I mentioned earlier, right? So this is us responding. So clinician, you've mentioned very little sleep and a lot of worry. Would it be okay if I asked you more, Tasha? Yeah, yeah. So safety, permission, curiosity. Tasha shares, yeah, anxiety has gotten pretty terrible. It's pretty bad. And I'm having intrusive thoughts. And I've been feeling overwhelmed, right? So immediately, when I hear overwhelmed, intrusive thoughts, I start to think about safety. You know, how terrible are these thoughts? How intrusive are they? What are they? So obviously her giving us that information can kick us into gear about how we need to address what's happening with her, what's truly happening with her. Because if it was the first interaction, the standard, she would have walked out and we wouldn't have known any of this. But because we engaged in a conversation through the lens of, trauma-informed bias-aware care, we got to learn a little bit more and about some things that are troubling her that we need to address, right? And so this is how we act. Obviously, we continue the evaluation, address her needs, and then and move forward with the planning with her. And so what became possible because of the engagement, because of the interaction through this lens, more of Tasha's experience became visible. Safety, we assessed for safety, which we may not have even done in the previous, interaction. And we plan together, okay, clearly you need some help. So what can we do, to help you? Because this can't persist, this could have long-term effects on your health and the health of your baby. So same patient, different conditions, more became visible. All because we changed the way that we engaged with the patient, the way that we interacted with the patient. So coming toward the end here. So the last section is reflecting. So this really is, we're closing the loop. We are trying to, understand what happens in our encounters. Where did we land? Did we put our biases on the shelf? Did we put what we think we know on the shelf? And what can we take from encounters that we have to apply them to future encounters so that we change the way that we are with patients? So initially, Tasha came to her appointment, worried, tired, but because we stayed curious, because we created safety and we created space for vulnerability, we got to learn a lot more than what we may have learned if we would have just done the standard task-oriented protocol, you know? We got to learn, there's some anxiety on the table, some intrusive thoughts were plaguing her, she's feeling overwhelmed, and she has some periods of hopelessness. So we got to do a safety assessment, so we got to understand, and then she got to see how serious this was, right? Because we're having a conversation. It is uh, um, a conversation that we're having together. So she is also a part of, the treatment planning, and so we can respond appropriately, get her connected to whoever she needs to be connected with, you know, and make sure that we keep an eye on what's happening as she continues to progress in her pregnancy. So, the important thing to highlight, asking did not create the risk. It created an opportunity to assess it. So it is super important for us to make sure that we are curious and we're paying attention when patients are in our spaces, so that we can look out for signals or cues that we may not be thinking, or what we see may not necessarily be what we're used to seeing, but we could miss because we're not paying attention to the clues, the cues, making things invisible visible, basically.
And just noting, Dr. Williams, you're doing great on time. We have 15
Mm,
minutes left, so you're doing well.
perfect.
Yeah.
Okay. So, what changed in the encounter? You went from tired, worried, still functioning, I'm all right, to, oh no, there's some things really going on that we can actually treat. We can help her reduce anxiety. We can help reduce intrusive thoughts, teach her some skills on, how to um, preoccupy her mind with something, or, you know, um, find hope, or whatever it is. We can connect her with someone who can help her, even if it's not us. And then we've got something to check back in on when she comes back in for her follow-up visit. Did Tasha change, or did our understanding change? She didn't change. She was the same patient. What changed is how we approached her and our understanding of her. So as you're reflecting, think, what did I initially assume? Remember when I asked you guys in the first poll, what do you see? In the second poll, I said, well, what are you drawn to? Hypertension. Are you closing the door right there? Up, hypertension. Let's jump on that and forget the rest. If you forget the rest, then you forget all of the things that we came to understand about her. And it could be another missed opportunity, you know, another death because we missed the chance to intervene when we had it. What became visible when we asked differently, you know? What might we have missed if we stopped at the first interpretation? What are you taking from each encounter into the next encounter that you have with the patient? And then our bias aware reflection, whose distress am I most likely to recognize? And who might I unintentionally normalize? So reflection should change the next encounter, not simply evaluate the last one. Take what we learn from Tasha and her experience to shape our future encounters with patients. And so the clinical conversation map that I created for you guys, I wanted to come back to that really quick to just remind you, like, sometimes it's hard if we're set in our way, it's hard for us to think about how do we change the way that we interact with the person. And so I thought it would be a good idea to have a visual to show you guys so that you can look at it and get some ideas about how you can change the way that you operate, the lens that you carry when you see each of your patients. So notice, how do you notice without jumping to conclusions? How do you interpret? Consider all the possibilities, not just jumping on, hypertension or one of the possibilities, and making sure that you're keeping your biases and your assumptions on the shelf. Okay. How do you respond? You're creating safety and opening for dialogue with the patient, and reflecting on how you are, how you present in a session. Is there anything that you can change up that would make shape the next encounter that and you could help that person, the whole person, better? So, in the guide that you guys will get, there are examples of questions that you can ask for each one so that you can try them on and see what fits with you and help you improve, the way that you are with patients. And so, what I hope you carry with you are these things. Just to recap, functioning does not always mean the person is well. You can be, that's how the person is not. Functioning is what the person is doing, not necessarily, it doesn't tell you how they're doing. When you're interpreting signals, cues and signals are hypotheses. They are not conclusions. You don't just jump, it got to be this and move on. Sit with what you're seeing and really assess and see what's going on with the patient. When you're responding to the patient, create space, create safety so that they can tell you. You don't ask the questions, they're not going to give you the answers, okay? They're not going to. And sometimes they don't even have the answers because they don't know what's going on. So sometimes just creating a space for them to process and have dialogue is an opportunity for them to also know, like, oh, wow, actually, this isn't good. This is really what's been going on with me. And then reflect on each of the encounters that you have so that you can make sure that you're operating in a trauma informed, bias aware approach, lens, and improve that for future sessions. Notice the person, check assumptions, understand the context, respond with partnership. You're working with the patient. It is a collaboration. That concludes. Oh, nope, there's a poll. There's one last poll, Adele. We got time? Yeah,
Yeah,
we got
yeah,
10
we're
seconds.
good. We are good.
Yes, what are you taking away? I know I hit a lot. I hit you with a lot, but like Adele has end of session reflection. What shifts are you most likely to carry with you to your next patient encounter? Like, what is a small thing? And for those of you who are not clinicians, who are not physicians, and maybe you are a patient, what can you take with you when you walk in with your clinical encounters with doctors? What can you take with you in those spaces to help you communicate what's going on with you?
Yeah, this is great. See a lot of responses coming in. I'll give it another 10 seconds. All right. I'm going to go ahead and end the poll. Thank you, everybody,
Thank
and
you,
share
thank you.
results.
Yeah. Yes. Reflection. Yes. Wonderful. Excellent. Excellent. I love that. Act. I hope you guys find this useful, honestly. Um, Even myself. Listen, when I was writing this, I was like, oh, that one patient that I had. I found with myself, that there are some things that I can change. It is a journey, it is a process. We are never going to reach the ceiling in how we are with patients. And so always reflect and look for ways in which you can improve the care that you provide. Real quick. So obviously I could not leave without telling you guys what we're doing at Indiana University School of Medicine and IU Health. So thought it'd be a good idea to let you guys know. So I've only been here for 2 years. Dr. Miller's been here for a bit longer, but her and I work together. We created Protect Lab. That's what it means. And essentially we provide clinical care, so individual counseling, coaching, inpatient supportive therapy. We provide supervision and education to trainees, to folks who are interested in perinatal mental health and trauma-informed care, trauma-focused treatment. And we also do research. And so we've got studies that we're engaged in right now. We're actively recruiting, excuse me, for two studies. My first study here, so very proud of that. My study is Project Pause, where we are evaluating written exposure therapy for perinatal PTSD for women with adverse pregnancy conditions. And then Dr. Miller is actively recruiting for her study, where she's evaluating, investigating um, narrative exposure therapy for perinatal PTSD and birth trauma. And so, should you know anyone that's interested, or you have patients who could benefit from mental health treatment, feel free to send them this. The QR code will send you to an interest survey that we have, where we're collecting information and calling people back to see if there's anything that we can do to offer some support to them. And we're always open for collaborations. So feel free to reach out to us for that as well. And the last slide here just gives you my contact information. So if you need anything from me, or you're interested, or whatever it is, you are welcome to call me or send me an email. And I did not put Dr. Miller's information up here, but if you want to talk with her, I can get you hooked up with her too. So feel free to connect. Thank you so much for listening to me. And any questions that you have, I would love to answer. Thank you.
That was awesome. You're getting a lot of love in the chat, so thank you so much.
Yay!
Yeah,
Thank you.
we do have a couple of questions in.
Yeah.
Great question from Faith. Awesome
Mhm.
work, Dr. Williams. Do you have any advice about what to do if we give space for patients to open up, but then there are little to no resources to help based on what they have shared with us? I want to avoid causing more harm. This is something I have experienced as a public health educator, so I was wondering if there are some more perspectives about it, or if the main goal in a case like Tasha's, for example, is that someone connected and cared.
Yeah. So, yeah. Resources, availability of resources is a thing. And sometimes it can be difficult to offer support to patients. And there is always something, okay? And so, in a situation like that, if you have a patient who would benefit from counseling, individual or group counseling, PSI has international postpartum support, has a ton of groups online every day for everything, okay? Grief, loss, anxiety, depression, everybody. I send patients there all the time to get some support from others who are experiencing, similar conditions. Um, Psychology Today is a good resource, so like go on there, find some therapists, that are accepting patients. So I guess the moral of the story is it's up to us to help figure out a way to help our patients. We can't leave them hanging because they might end up a statistic because we didn't intervene when we could, And even if it means you're reaching out to colleagues, call me. I can help you find someone in that area. You know what I mean? I see emails on listservs for psychology all the time. Hey, I got a patient in this state and there's nothing here. Do you guys have any resources? Like there's always a way to find something for a patient, but we don't want to leave them hanging and give them nothing, or just ignore, because that could be a statistic because of that, and we don't want that. We want to save lives.
That's awesome. Thank you. Um, we have another really good question. How does medical distrust play a part in these processes you've shared?
It plays a huge part, right? Because of the way that Black women, women of color, you know, are situated. They're situated across systems that are not designed for them. And so they're mistreated, they're dismissed. So why would someone trust us, right? The onus is on us, though, to create space for them to build trust, you know. Not saying it's going to be easy because it's not going to be, but that we're not there. We're not doing the job for it to be easy, right? We're doing it because we want to save lives, And so how do you um how do you find it within yourself to help women who may find it difficult, to trust you? Like, how do you operate with that challenge? Because we do it all the time, right? It's up to us to figure it out, so that we can help them despite the barriers, despite the obstacles that they face. You know, it's up to us to understand why they're even presenting that way, you know. But
Yeah,
it does. Medical mistrust is another obstacle, is what it is.
yeah, that makes sense. Thank you so much for taking the time. I'm gonna have you, if it's okay, advance to the next slide. I think we just have a couple
Yes.
like really quick things.
And if there's more questions, they can email me or whatever. I
That's
skip the slide?
perfect.
Hold on. Sorry, I skipped
Oh
one.
yeah,
Let me go
you're
back.
good.
Oh, this one.
We had the both
We
of us
already
have
had
it.
them. Okay, but this
Yeah, we're
one,
good.
Kara. Okay.
So, if you want, so this, is a great example of a training that's really focused on trauma-informed care. Dr. Williams, you're so good at this. Um, we have lots of these that span a lot of different areas of health, not just maternal health. So if you want to sign up to be on our listserv to hear about more of them, this QR code will take you to that. Or Kara, who introduced herself in the beginning, um, her contact info is here. You can contact her. You can sign up at updates@hct.org if you want to be on our trauma informed care training list. And then next, please. This is a QR code that will take you to our eval. It's pretty short. We just want to hear what you thought about this webinar. And I know you got a lot of love in the chat, Dr. Williams. I'm super happy that y'all enjoyed this and it was a good use of your time. That's what we want, right? An impactful lunch hour. We can eat our little yogurt or chicken or whatever and, learn something at the same time. So that eval will also be in the post email that goes out if you don't have a chance to do it now. And then next slide, please.
Checking out the chat because the first time I saw it.
Yeah,
Okay, there
you're
we go.
good. You're good. So this series that Dominique and I were mentioning in the beginning, we have a couple more webinars as part of it. We have two more this year, and then we'll have more in 2027. The next one we have is on the 23rd of September. It's supporting dads and partners in perinatal mental health, which is like there's so much we could talk about in perinatal mental health. This is just one more chapter to explore. So if you want to register for that, there's a QR code here. I also did drop the link in the chat. And I'll leave this meeting up for a couple of minutes so that people can have all the links in the chat as well. Next, please. And then this is just for folks in the Indianapolis area. So HCET is starting a Indianapolis area trauma-informed care collaborative. So we're having a series of 4 meetings, the first Tuesdays of the month for September, October, November, and December, in which we are going to speak with people who work in Indiana in healthcare, service industry, wherever we're connecting with patients or clients to talk about building this trauma-informed care standards and network that Kara was speaking about in the beginning. So I am going to put the link in the chat for that. And I apologize, I'm putting the long links. For some reason, a lot of times hyperlinks do not work. It drives me absolutely bananas. So that's why you see the really long links in the chat. But if you would like to sign up for that, we request that you do sign up by the end of the week as we're getting close to doing our first session. Our first session is on September 1st, and then we have one the first Tuesday of October, first Tuesday of November, and first Tuesday of December. Next, please. That might be it. Yeah, thank you all so much. Thank you, Dr. Williams. It was so good to hear from you. Thank you, everyone, and we will see you on the next one. I'll just leave the Zoom up for a minute so people can access the links if they want, but you're free to go. Thank you, everyone.
Thank you.